Karthik and today I am going to take topic of Odontogenic Keratocyst. So first in the introduction we are going to see the definition of the cyst. Define cyst. The cyst is a pathological cavity having fluid or semi-fluid or gaseous content which is not created by accumulation of the pus. And most cysts, but not all, are lined by the epithelium. That means no need to be all the cysts are lined by the epithelium. There are some unlined epithelial cyst also is there. I mean non-epithelial cyst also is there. So next I am coming to the classification of cyst of jaw. So basically it is classified into non-epithelial cyst and epithelial cyst. So this epithelial cyst is further classified into inflammatory cyst or the developmental cyst. These developmental cyst is again further classified into odontogenic cyst and non-odontogenic cyst. So first I am going to list out the epithelial cyst of the developmental organ. As I said before, the developmental organ cyst has a two types, it's a odontogenic cyst and non-odontogenic cyst. Under odontogenic, gingival cyst of infants, odontogenic keratocyst, dentigerous cyst, ruptured cyst, and gingival cyst of adults, and developmental lateral periodontal cyst, outright odontogenic cyst, granular odontogenic cyst, and calcifying odontogenic cyst. These are the cysts are coming under the classification of odontogenic developmental cyst. Non-odontogenic cysts are mid-palatine cyst of the infants, nasopalatal duct cyst, and against nasolabial cyst. So, what are the inflammatory cysts? It's called residual cyst, paradental or juvenile paradental cyst, and inflammatory collateral cyst, and radicular cyst. This is the most common inflammatory cyst occurs in the oral cavity is radicular cyst. What are non-epithelial lined cysts? These are the cysts, as in definition we say, no need to be all the cysts are lined with epithelium. The first one is solitary bone cyst and is the aneurysmal bone cyst. Okay. Now I am coming to the topic of the day. So today's topic, as I said before, we are going to take about the odontogenic keratocyst. It is a very rare benign developmental odontogenic cyst of the jaw. The OKC usually fulfills its definitions of the cyst, but it's coming to the neoplastic natures and recurrence rate and the aggressive natures. It could be could be a cystic tumor. Why it's called keratocyst? Why the name is called something different from the odontogenic cyst, some other odontogenic cyst? Because this epithelium is produced so much of keratin fill in the cystic lumen. That means this keratin will be seen in the epithelial layer, lining of the cyst. Usually 8 to 10 layers of the keratins will be seen in the lining of the cyst. So next, what is the difference from the other cyst? Why its OKC is different from the other odontogenic cyst? There are three major points is there. That is because of the increased growth potential, that means aggressive natures and increasing recurrence rate. Comparing to the other cysts, it has a more recurrence rate of the 13 to 16% of the cases will be recurrent in the next 5 years, and it's a cyst associated with the syndrome. So the syndrome is nevoid basal cell carcinoma syndrome. And what is the origin? So from where it's originating? So there are two origins there. It may be from the remnant of the dental lamina. The next one is the extension of basal cells from the overlying epithelium. These are the origin of the odontogenic keratocyst. And there is a controversy between the cyst or tumor. If the OKC is coming under as a cyst or tumor. In the beginning, first in 1971 and 1992 classification of WHO, it was coming under developmental odontogenic cyst. And again in 2005 classification, they changed to the tumor category with the name of keratocystic odontogenic tumor. And again 2017, the KCOT was pivoted to the category of cyst. And now in 2022 classification of the WHO is coming under one cyst only. So it is a odontogenic cyst, not a tumor. So how its OKC is coming? What is the pathology behind it? What is the pathogenesis? So why it's called maybe tumor or cyst? Because with this gene PTCH1 mutation, there is a controversy between whether the cyst or tumor, because this is oncogenes. It's mutating and converting into tumor. So that's why there was a controversy. So both sporadic and syndromic cases will have the PTCH1, but it is not all the cases. So this gene will activate the SHs. These SHs will bind to the It is S-Catches is a oncogene which bind to the PTC1. So again it will increase the level of SMO, it's a smooth end oncogenes, which will increase the GIL protein. It is an oncogenic protein which increase the cell proliferations, and increase the survival potential. So because of increased proliferation of cells, lot of cells will be proliferating, and at the same time cell death also is reduced. So the number of cells will be increased. So obviously the growth of the cyst will be more. That's why it's increasing the survival potential. So coming to the major clinical features, it may be affect all the age group, and peak incidence will be second and third decades, and it is a bimodal actually. It can be occurs in second and third decade, or maybe in the fifth decade. So, but why I am mentioning the second and third decade is, it is more commonly will be seen in second and third decade. So coming to the gender predictions. So which gender will most commonly will be seen? So obviously it will be seen in the slight general predilection of the male when comparing to the female. So always male will be higher. And next we coming to the region. Which region is most commonly affecting? It's molar and ramus region. That means it's posterior part of the mandible. And usually the cyst might be a small or large lesion, but it's a solitary lesions will be seen. Sometimes multiple cysts will be seen in the syndrome associated with nevoid basal cell syndrome, as I discussed before. Why it's different from the other odontogenic cyst. So I'm coming to the site distribution. So what is the prevalence of this cyst according to the region? So as I said before, most commonly will be seen in the posterior mandible. 49% of cyst is arising in the posterior mandible, followed by the posterior maxilla with 20%. So next, third most common region will be the anterior maxilla and the anterior mandible, and the least common sites will be the premolar region of mandible and premolar region of the maxilla. So what are the common clinical features will be seen, and symptoms will be given by the patient. Patient might give the symptoms like pain or swelling or any cystic discharge from this site of the swelling or the pain will be given by the patient. Sometimes patients feel paresthesia occasionally in the lower lip and the teeth. Why the paresthesia is coming? So as I said before, it's most commonly will be seen in the posterior mandible. So what is the important landmark is there in posterior mandible? It's inferior alveolar nerve. So once this cyst is involved in the inferior alveolar nerve, it will impinging or maybe it's compressed the nerve, it will cause the paresthesia. So obviously the cyst expands, next to it what will happen? Usually it will displace the adjacent structure. What is the adjacent structure? Teeth. So it might penetrate the cortical bone also in further stages, and it will reach the soft tissue. So some cases, unidentified cases, asymptomatic cases, large lesions will lead to the pathological fractures of the bone. Why it's asymptomatic? So because maybe expand large size involved in the maxillary sinus, it will be asymptomatic because no swelling will be seen. Or maybe it's growing in the ascending ramus or condyle or coronary process also, there is no swelling will be seen. Why? What is the reason behind is growing there? Because it occurs in the medullary cavity. So it will grow in the medullary bone. So clinical expansions will occur at the very late stage, not early stage like other cysts, like cyst or tumors, maybe ameloblastoma or dentigerous cyst. So what are the syndrome? Usually we will be having the multiple OKCs. First one will be the Gorlin-Koch syndrome and Marfan syndrome, Ehlers-Danlos syndrome and Noonan syndrome. Then coming to the radiological findings. It can be unilocular or multilocular. In some cases, it can be unilocular with a well-corticated margin and well-defined radial efficiency. Usually, the cyst occurring in the anterior region of the mandible, like premolar region or canine region, it will show you unilocular appearance. The multilocular lesions usually seen in the posterior mandible, maybe in third molar region or ascending ramus. Usually, it will be having the multiple septate with the well-defined margins. It's might similar to the ameloblastoma, and because of this, it might be differentially can be diagnosed as dentigerous cyst. Maybe the unilocular appearance in the posterior mandible will give the appearance of the dentigerous cyst, or multilocular appearance in the posterior mandible can be given as ameloblastoma, or maybe the odontogenic myxoma can be given the differential diagnosis for this thing. So according to the radiographic finding, it can be classified into 4 types. First is envelopmental type, replacement type, extraneous type, collateral type. So what is envelopmental type? It's enveloping the fully unerupted teeth. I mean third molar or maybe any molars is impacted the posterior region. And B is replacement type, which is replacing the teeth surface place. So normally teeth will be erupting here, it is replaced by the cyst. And third is extraneous. It is extraneous means away from the teeth. So it's obviously its ascending ramus will be affecting with the cyst. And collateral type is that means it's lateral to the tooth. So in between the two roots, cyst can be occurs. It may be diagnosed as lateral periodontal cyst. So coming to the differential diagnosis. As I said before, dentigerous cyst, ameloblastoma or odontogenic myxoma. These are the main differential diagnosis can be given because it's occurring in the molar region and ramus, and all these 3 lesions will be seen in the same region. So histopathologically, how we are confirming to the diagnosis. So we can confirm with the corrugated parakeratotic lining and some lumen surface and palisading arrangement of columnar and base cuboidal basilar cells, and lack of retipages and keratin flake might be present in the cystic cavity. Because of histopathological finding only, we can come to the final diagnosis of odontogenic keratocyst. Why it's occurring high? Reoccurrence is high. I mean, that means 13 to 16% is quite high recurrence when comparing to the other odontogenesis. It may be the incomplete removal of the cystic lining, thin fragile lining, increased mitotic activity or budding in the basal layers, and remnant of the dental lamina which is not associated with the original OKC. Maybe the growth may be arise from the satellite cyst or daughter cyst or remnant or cell rest can be also give the high recurrences. Coming to the treatment, there are numerous treatment plans is there. The first will be the enucleation and multiplication is a classical treatment for the cyst removal. In treatment of OKC, we are using the ethanol and chloroform galactic acetic acid combination. It's called Carmine solutions. It acts as the chemical necrosis which kills the cystic lining and prevents the recurrence of the cyst. So what are the points there to remember when coming to the odontogenic keratocyst? The second most common odontogenic cyst of the oral cavity, more common in male and mostly seen in the posterior mandible. Usually it will be show the anteroposterior expansion. It shows a high recurrence rate when comparing to the other cysts from 13 to 60%, and the Carmine solutions are using to prevent the recurrence of the OKC. Thank you.